is usually for type 1, a very sensitive type 1 pregnancy. And I had just, in the past 3 years since I moved to India, had 3 type 1 patients successfully delivered with insulin pump. So it gives the best control, especially prevents, you can be aware, hypoglycemia, which is a major fear, as much as you want the tight control. My goals are 60 to 90 fasting and less than 120. I do not allow the patient to go beyond that. A1C of 6 and below. Period. So in that case, the patient is going to have severe hypoglycemia. Insulin pumps is the way to go. So moving on to the next session. Awesome. I would like to invite Dr. Gerald, the chairperson. Thank you, sir. He's our senior physician and chair professor of medicine at Madurai Medical College. He worked in the Endocrine department of Madurai. And I would like to invite Dr. B. Palnikumaran. Welcome. Consultant physician and diabetologist, Palnikumaran Specialty Hospital, senior assistant professor, Department of General Medicine, Madurai Medical College, Madurai. And he is the GED, MED gold medalist student 2014, published research articles in various national and international journals. Welcome and thank you. Over to the chairperson.
Good morning to everybody. First of all, I convey my sincere thanks to the organizers, especially Dr. Marvel, for the opportunity. First topic, we have got 2 topics in this session. First topic is endocrine hypertension to suspect. I request our speaker, Jayapara Sam, to highlight the topic. The endocrine hypertension comes under the secondary hypertension. When to suspect, actually, whenever the hypertension occurs below the age of 35 years, at the first sight, or after the age of 55 years. Second point, when it is not controlled with 3 drugs, with the 1 drug, naive. Third point, resistant hypertension. These are the 3 points when we have to suspect the secondary hypertension. Among the endocrine hypertension, hypertension, Down syndrome, and persistence. These are the 3 important things we are expecting from the speaker. Apart from that, even acromegaly, hyperthyroidism, hyperparathyroidism, all these things contribute to hypertension. Therefore, we are very much eagerly waiting for your speech, sir.
Thank you, sir, for kind introduction. Very good afternoon to all. At the outset, I would like to thank the Marvel and team for giving me this opportunity. In the next 20 minutes, I will be covering introduction about endocrine hypertension and brief details about 2 common endocrine hypertension diseases, that is Down syndrome and hypertension, as mentioned by sir, and finally conclusion. So, what is the proportion of hypertension is caused by endocrine disease? So 85% of hypertension is just essential. There is no specific etiology for this. So only 15% of cases are secondary hypertension, and that includes both renal diseases and endocrine disease. So when to suspect endocrine hypertension? The first one, like if the hypertension is coming episodic, sudden onset, and spell labile hypertension, and this is applicable for pyochromocytoma. And second is if it is not accompanied by the usual contributing factors like the other components of metabolic syndrome. Usually in the hypertension, the diabetes, dyslipidemia, and obesity and family history are accompanied like usual contributing factors. If those are not there, young fellow, thin fellow, and some atypical symptoms, then we can suspect endocrine hypertension. And third is associated with abnormal clinical or laboratory findings. There are few syndromes where I will discuss in detail later. We can get the clinical findings. Like suppose patient having neurofibroma with pyochromocytoma, so we can get the cutaneous markers of neurofibroma. Similarly, the pheochromocytoma is a part of multiple endocrine neoplasia type 2A or 2B. We can see we can find the evidence of other features of this syndrome. And the last one is resistant to therapy. The blood pressure is not controlled with three medications, including a diuretics, or patient is requiring four medications for control of hypertension. Then we can suspect if we are dealing with a case of endocrine hypertension. So, what is the beauty of diagnosing the endocrine hypertension? So, two important aspects of endocrine hypertension diagnosis is there, which is not there in essential. If you will diagnose the underlying disease and you will treat, permanently hypertension may disappear in contrast to essential hypertension. And second thing is, so obviously the hypertension is curable in the endocrine cases. Suppose patient having pheochromocytoma, you remove the tumor, the hypertension will disappear. So if you miss the diagnosis, unnecessary patient will be on antihypertensive drug for the lifetime. And another problem is in endocrine hypertension, in contrast to essential hypertension, even if you control the hypertension with antihypertensive medication, the hormone itself will cause the end organ damage that you cannot prevent with antihypertension. For example, so patient is having pheochromocytoma, there is a high adrenaline and non-adrenaline. You give the antihypertensive, BP will be controlled, but the kidney and the cardiac damaging property of noradrenaline and adrenaline cannot be prevented with antihypertensive. So these are the important points why we should not miss the diagnosis of endocrine hypertension. So so this is the prevalence of different endocrine causes of hypertension. The most common is Conn syndrome, and that is the prevalence varies from 1.5 to 50% in different series depending on how you are evaluating for the Conn syndrome and which patients of hypertension were included. And the second is pheochromocytoma. This is responsible just less than 1% of hypertension patient. And the other diseases like Cushing syndrome, hypothyroidism also can cause. Like hypothyroidism mainly cause diastolic hypertension, and the hyperthyroidism can cause systolic hypertension. And similarly, other diseases like CA, specifically 11 beta hydroxylase enzyme deficiency, leads to congenital adrenal hyperplasia with hypertension. Even primary hyperparathyroidism because of high calcium can cause hypertension. And also growth hormone excess, and also patients are put on oral contraceptive pills, particularly the estrogen component may increase the hypertension. But I will discuss in detail the first two diseases, that is Conn syndrome and pheochromocytoma. So coming to the Conn syndrome, so these are the different etiology of Conn syndrome. The 35%, that is one third of Conn syndrome is caused by adenoma. Remember, the Conn syndrome, the most common cause is not adenoma, it is bilateral adrenal hyperplasia, in which case there is no role of surgery. Patient will be put on lifelong aldosterone antagonist. So the diagnosis of Conn syndrome does not mean we will offer surgery and it will be permanent cure. 60% of cases it is hyperplasia, in which case patient has to be put on aldosterone antagonist, and then 30% of case we can diagnose the aldosterone secreting adenoma, in which case surgery will be for permanent cure. So which patient we should screen for Conn syndrome? If the patient is having sustained BP more than 150/100, and already I mentioned about the resistant hypertension, and the patient of hypertension is developing spontaneous or diuretic induced hypokalemia. So young patients, hypertension with hypokalemia, spontaneous or diuretic induced, requiring multiple medications, difficult to control the blood pressure, we should rule out consider. These are other indications like hypertension with adrenal incidentuloma, hypertension with obstructive sleep apnea, hypertension with family history of early onset of hypertension or CP, that's less than 40 years, or any patient first degree relatives of patients with Conn syndrome. So one thing we should remember, hypokalemia is not mandatory for diagnosis of Conn syndrome because 60% of cases of Down syndrome may not have hypokalemia. So normokalemic hypertension constitutes the most common presentation of Down syndrome. So rather, they may develop hypokalemia once you have used diuretic as a treatment for antihypertension. So this is the protocol. First, we will suspect in a patient of hypertension to rule out endocrine causes. Second, we'll do aldosterone renin ratio. If that is positive, then we'll go for imaging. And depending on the imaging, adrenal venous sampling may or may not be required, depends on whether we are planning for offering medical therapy or surgery. So, what is the protocol for doing aldosterone and renin activity? Patient, it should be done before 10 o'clock morning fasting. After patient being ambulant for at least 2 hours, and before taking blood sample, patient should be sitting for at least for 15 minutes. And if the patient having hypokalemia, that should be corrected, and there should not be any restriction of salt. And for doing workup for Down syndrome, patient can be allowed only on these three drugs. Any other antihypertensive drugs will affect either aldosterone level or renin level. Only three drugs, that is pyramamine, hydralazine, and prazosin. These three drugs, there is absolutely no interference with the interpretation of aldosterone and the renin activity. And this is the cutoff. Aldosterone level should be more than 15, and plasma renin activity should be less than 1, and the ratio should be more than 20. So here it's a very nice graph. So this is the like normal patient. This is essential hypertension, and this is the Down syndrome. So if you take the cutoff of 20, that is aldosterone and PRA, we can exclude all the normotensive patients. But still, some percentage of essential hypertension patients may have cutoff of ratio of aldosterone and PRA ratio more than 20. But if you take cutoff 100, so absolutely all the essential hypertension patients can be ruled out, but some Down syndrome patients also can be ruled out. So the message is, even if you take cutoff 20 aldosterone ratio, some essential hypertension patients can be included, and those patients can be excluded by doing confirmation tests and by doing imaging. So here comes the role of confirmation test. Out of these 4 confirmation tests, the commonly used is IV saline suppression test. That is, patient has to be put on 2 liters of normal saline in ambulatory position over 4 hours. And after 4 hours, if do just aldosterone level, if it is less than 5, then Down syndrome can be ruled out. So definitely there's a role of confirmation test, those borderline cases ratio, like just suppose ratio is just 25, whether you are dealing with essential hypertension, Down syndrome, in that case it will be helpful. But remember, we cannot infuse 2 liters of with somebody having severe hypertension and congestive cardiac failure or cardiac arrhythmia or severe hypokalemia or advanced kidney disease. So once patient having positive confirmation, positive screening test and confirmative test, will do CT adrenal. NCCT is sufficient enough to diagnose Down syndrome. Usually the size is less than 2 centimeter, and that they used to have hypodense. HU used to be low, less than 5, because they are lipid rich adrenal adenoma. MRI has no advantage over CT scan, and high resolution CT scan can diagnose as small as 5 millimeter Down syndrome. So here is the patient having an adenoma in the medial limb of the right adrenal gland. So this is the classically the adrenal adenoma causing Down syndrome will be subcentimeter, like 5 to 8 millimeter or maximum to 2 centimeter. If there is no adrenal adenoma, both side adrenal glands are normal or hyperplasia, or the patient having biochemical test positive, in that case we can do adrenal venous sampling if facility is there to get the idea which side of adrenal gland has to be removed, even if imaging is normal. And another interesting thing is the patient is young, less than 35 years, and spontaneous hypokalemia, aldosterone level is very high, and then the unilateral adrenal lesion, there's no role of adrenal venous sampling, we can go straight for the surgery. So this is brief about adrenal Power syndrome. So we'll go to the other common endocrine disease like pheochromocytoma. This is not a disease of 10% we used to read in our textbook when we were undergraduate. Now the 10% has become 30%. In 30% cases, it is familial, and 30% cases it is bilateral, and 30% cases it is extrarenal, and 30% cases it is malignant. In contrast to 20% used to be in literature few decades back. So who should be screened? If patient having resistance hypertension, particularly intermittent, and there's episodic triad, that is headache, palpitation, and sweating, and the patient having sudden increase in hypertension after receiving any anesthesia, or patient having family history of pheochromocytoma with adrenal incident. So these are the genetic syndrome which are like one component is pheochromocytoma. Men 2A, there in addition to pheochromocytoma, we can get medullary thyroid carcinoma and primary hyperparathyroidism. And men 2B, where we can get medullary thyroid carcinoma, multiple mucosal neuromas, and marfanoid habitus, and also corneal thickenings. And the VHL, where in addition to pheochromocytoma, we can get renal cell carcinoma and multiple cysts in different organs, and hemangioblastoma in the cerebellum and the spine. Similarly, in the NF1, we can get neurofibromatosis nodules and the capillary spots. And also, we can get paraganglioma in different genetic syndrome like succinate enzyme B and D deficiency. So, if you are suspecting endocrine hypertension, specifically pheochromocytoma, you should look is there any other features of syndromes where pheochromocytoma can be one component. So here one of our patient neurofibroma showing multiple neurofibroma nodules, and this right side patient the main to be having marfanoid habitus and mucosal neuroma, and also in slit lamp examination there is corneal thickening. And this is a patient of VHL having retinal hemangioblastoma. In addition to getting hemangioblastoma in cerebellum and spine, we can get the finding in retina also. So similar to Cohen syndrome, any endocrine tumor, this is the classical first clinical suspect. Then we'll do the biochemical testing, then structural or functional imaging, and followed by surgery. So after clinical suspicion, next we'll go to the biochemical test. The best investigation is plasma free metanephrine and non-metanephrine. So here different series from Bioclinic and from NIH series, you can see the plasma free metanephrine and non-metanephrine sensitivity varies from 96% to 100%, and specificity from 85% to 100%. This is the investigation of choice. So, in contrast to plasma-free metanephrine and non-metanephrine, BMA though is having low sensitivity but specificity is very good. So, if you combine these two investigations, so we can get almost 95 to 99% sensitivity and specificity. So, remember one thing: before collecting the sample for plasma-free metanephrine or non-metanephrine, so these are a few things we should follow. Patients should be in the overnight fasting, in the supine for 30 minutes, in the morning time should be done, and to avoid stress-induced catecholamic surge, we should collect the sample in the previously placed cannula, and the medications that can cause interference in the metanephrine, non-metanephrine assay should be avoided. These are the different drugs which will affect both plasma and urine beta and non-metanephrine. And after clinical and biochemical confirmation, we'll go to the imaging. So here you can see the left side is the kidney, and in front of kidney is the left side pheochromocytoma is a non-contrast imaging, and in the contrast imaging you can see post contrast there is enhancement. And the MRI in the T2 it appears very bright, that's called as light bulb sign. So this is also specific image finding in the pheochromocytoma. And to rule out metastasis, if you are suspecting it's a metastasis pheochromocytoma, so both for diagnosis and also to offer the MIVG therapy, we can do MIVG. So here the nuclear scan, here is the patients having the right side pheochromocytoma. So these are the sensitivity and specificity of different imaging modalities. CT scan having 98% sensitivity and MRI is 100% and MIVG is having 78%. Like VMA is having better specificity, similarly MIVG is also having better specificity but lower sensitivity. So finally, to conclude from my presentation, endocrine hypertension is an underdiagnosed treatable cause of secondary hypertension. Adrenal disorder, specifically Conn's and pheochromocytoma, relatively common cause for endocrine hypertension. Specifically, Conn's syndrome, in the recent series it has shown it can be present up to 15% of so-called essential hypertension. And adrenal hyperinsulinoma should not be overlooked, even if it is very small, specifically for Conn's syndrome, because classically the Conn's syndrome is caused by the adrenal adenoma size is 5 to 8 or 5 to 10 millimeter. So it should not be overlooked, even if it is very small in a hypertensive patients. And the specific clinical features of endocrine like neurofibromatosis, features of VHL, or features of multiple endocrine neoplasms type 2A or 2B should be looked for the screening. That will give clue so that we can diagnose easily to be dealing with a case of endocrine hypertension, not a case of essential hypertension. Thank you for your time.
Thank you for your excellent presentation. Any questions from the audience, sir? So, few points about the extraordinary programs.
Extraordinary pheochromocytoma, it is seen almost up to 20-30% of cases, and here the one of the common causes genetic syndrome due to succinate dehydrogenase B deficiency, and the most common site is abdomen pelvic area. There is bifurcation of the aorta, that is gland of Zucker canal, the most common site. And another interesting thing is, because for the synthesis of adrenaline, the tumor should be in the adrenal gland. If the tumor, that is paraganglioma, in contrast to pheochromocytoma, which is outside the adrenal gland, present in the sympathetic chain, will not able to produce adrenal glands. So here, if you do the biochemical test, mostly it will be norepinephrine secreted. That's a very specific flow. So if you are getting only norepinephrine high in the biochemical testing, either we are dealing with a case of paraganglioma, that is extrarenal PO, or we are dealing with a pheochromocytoma specifically in the background of VHL. So in VHL, even if it is pheochromocytoma, it will be exclusively noradrenal, that is norepinephrine secreting, but a paraganglioma, it is always noradrenal secreting.
Chance of malignancy, sir?
Chance of malignancy, it is in both cases, either it is pheochromocytoma or paraganglioma. It is not specific. If it is extrarenal, the malignancy risk is more. It's not like that.
Thank you so much, sir. Any other questions from the audience?
Thank you very much for your time. When we were students, we were taught that essential hypertension is up to 90 to 95%, and endocrine hypertension is only 5%. Now that we are recognizing and picking up more endocrine hypertension, the condition is slowly reversing.
Yeah, definitely, because that is mostly previously it was underdiagnosed, and that is Conn's syndrome. Pheochromocytoma will not be missed. Conn's syndrome means recently, I think 2 years back, in AIMS New Delhi, with the help of both endocrinology and cardiology department, they have done a study. Specifically, they have done the prevalence of Conn's syndrome in young resistant hypertension. It was present in 35% of cases. So depending on which patient you are screened, even the 5% has increased not only to 15%, even to 20 to 30%. If you are screening young patient are requiring multiple antihypertensives.
Failure to pick up these cases early will produce vascular changes, so that the hypertension becomes more permanent and more irreversible. That is the whole problem. I am very happy that you stressed that point.
Awareness should be there. Awareness should be there.
Thank you, Dr. Moses. Really, that was very helpful. And Dr. Saad, it was a very difficult topic that you really done with the ease. Thank you very much. I want to welcome Dr. Gerald to fellow state